Well, I'd like to thank Dr. Sedlack for joining us today. My name's Rob Enns. I'm from St. Paul's Hospital in Vancouver in Canada. Dr. Sedlack is joining us from Mayo Clinic, Rochester, and his paper has been very well received by the GI community in training and competency in colonoscopy, assessing and defining competency and standards. I think this has added just an immense amount of material and information, particularly for training for everybody, and it's going to pave the way for many changes. And I just wanted Dr. Sedlack to perhaps just give us a little bit of background on the study and where things have come from in the past decade, in particular in colonoscopy, and that led the way to the paper.
Absolutely, I'd be happy to. Well, sort of the background behind why we did this study. The ASGE and all the other GI societies have been recommending for 15, 20 years now that 140 procedures or 140 colonoscopies are required by a trainee before competency can be assessed. Unfortunately, these guidelines and recommendations offer no guidance as exactly how to assess nor what defines competence. So really, and it's not any fault of their own, it's just that data didn't exist. Right. So our goal was to sort of fill that void and define how can we assess competence in colonoscopy, and how are we going to define competence based on those skills assessments.
So in a previous study, I think you've looked at and validated a scoring scale, Mayo Colonoscopy Skills Assessment Tool. And I was hoping you could fill us in a little bit. I've certainly read the paper. I don't think I could quote every portion of the skills assessment tool, sure, but maybe you could tell us the general concepts behind it and what the key structure of that tool.
Sure. So to develop this form, the publication you're talking about was actually in GI Endoscopy this past December, where we validated the tool itself. And what the tool was a means to assess not only the core motor skills, but also incorporate core cognitive skills, something that's been very lacking in a lot of assessment models. So we really deconstructed the colonoscopy procedure into these core cognitive and motor skills, and came up with a form that can best assess these different aspects of the procedure.
I want to congratulate you for that work, because I think the cognitive aspect, everybody talks about cecal intubation rates or even adenoma detection rates, but to try to bring in some of the cognitive aspects, I think is the real advance, and perhaps somewhat of a novel way of thinking all of this.
Absolutely.
So when you did this study, describe what you did with this study and over what time period it went through.
Sure. So once we had the form, we decided, okay, now we've got to define learning curves in our trainees. And from those learning curves, we can identify competency benchmarks. So what kind of performance or behavior is really going to define the first level at which a trainee is minimally competent. So using the form, our staff over a 3-year period filled this form out on our fellows on every colonoscopy that they performed. And that allowed us, based on their scores, to plot their average scores over the duration of their training program. And from that, we were using somewhat of a standard method, at least in education setting, but something not commonly used by many non-educators, is what we call standard setting techniques, is what defines competence based on scores of results from an exam, say, or whatnot. And we use something called the contrasting groups method, sort of a convoluted method of plotting distribution curves of performance of a non-competent group and a competent group that is better fleshed out in the manuscript itself. It's somewhat complicated and be sort of long-winded here, but based on the comparison of these two groups, we're able to define what scores set the bar. We were able to set the bar for what define minimal competence.
And I think for your various characteristics, you had kind of scores 1 to 4 for each of them. Can you describe what those scores are?
Sure. Well, scores 1, 2, and 3. These were a novice, intermediate, and advanced trainee that indicated that the fellow's skills were progressing towards competence but had not yet achieved competence. Whereas a score of 4 defined the skill set had been acquired that they could perform that individual skill independently without the staff being in the room. So it defined competence.
So you're aiming for a 4,
Exactly.
or close to it.
It's just like the ABC scale, you know, 4.0, a 3.0 average. Yeah, exactly.
And so what did you find in the studies? I think you assessed 41 fellows over their 3 years, right?
Correct. So we were able to define some very nice learning curves for each one of these skill parameters, and what we found was that in order to achieve competency in all of the skills, it took roughly 275 colonoscopies to achieve that minimal benchmark, which is, the implications of that, it's certainly a lot more than the 140 GI societies have been recommending.
And certainly a lot more than many more than many other societies.
Absolutely.
I come from Canada, so I have even a different perspective yet.
Sure.
So I think that's, it's more than any society, and also Canada recommends too. Now, what about those that might say, well, some people pick it up just a lot quicker than others, and I think I'm pretty quick at this. I think I only need 30.
Absolutely. Well, from our data, we were able to say that yes, people do learn at vastly different rates. Our earliest people were able to achieve our minimal competence benchmarks at 200 procedures, whereas some took up to twice that, to 400 procedures in order to achieve these. So, but I will point out that nobody was competent at the usual benchmark of 140 procedures. And that would corroborate some studies that were recently done by Spear et al. Out of Wisconsin.
So even the fast learners need
at least
around 200. Yeah. And so I think it's just really exciting work, and I think it's going to be cited and quoted an awful lot, which I think is great. Now, where do you think? First of all, describe what you're doing at Mayo with these numbers, because obviously there's adjustments for all of your GI trainees, and as far as ASG and other societies, where do you think they should go with it?
Absolutely. Well, internally at Mayo, we've been actually using the results of creating individual fellow progress reports for our training director that can help identify trainees that are struggling and are falling behind the learning curve. So somebody who's a standard deviation or 2 below the average learning curves, so we give remediation and are able to identify them much earlier and give them the extra time and procedures that they need to catch back up. Where this is going outside of Mayo is, based on these numbers, the ASGE is currently rewriting the colonoscopy curriculums to reflect these higher numbers, but more importantly is re-stressing the need for a performance-based assessment. Rather than basing somebody competent based on the numbers of procedures that they've done, they really want to stress that use of a tool like the MCSAT to do a performance-based assessment is critical.
Well, I really want to thank you for spending some time with us today, and thank you for all the work that you've done with this. As I say, I think it's going to be quoted for a long time.
Well, I hope so.
Much appreciated.
Thank you very much for your time.